See my screen. Yes, Washira. How are you? If you have any question, you can ask. Your microphone is on. This might look long, but it's not. Okay. For the biliary tract and gallbladder, there are only three lesions. In the pancreas, again, there are mainly three lesions, and we are done. So I'll just mention the most common lesions that we see in these two organs. Okay. The rest we'll mention in passing. So pancreas, biliary tract, and gallbladder lesions, both neoplastic and non-neoplastic. So we look at the inflammation, mainly the inflammatory conditions, cholecystitis, cholangitis, a few congenital disorders, but not very common in the gallbladder. If they are mentioned, they're normally mentioned in the context of the liver. Tumors, not common, but extremely serious. In fact, the two cancers we are going to mention today tends to have dismal prognosis, terrible prognosis. Okay? And it's one of those carcinomas or cancers that you rarely meet your patient even a year after making a diagnosis. Okay? So in the gallbladder, we are mainly dealing with the inflammation, so the cholecystitis, and then the gallbladder also have stones. So the two main lesions we are going to deal with in more details will be the cholecystitis and then the stones. We call them cholelithiasis. Now, in the pancreas, mainly the inflammation, and the most common inflammatory lesion here will be the acute pancreatitis. There's also the issue of the chronic pancreatitis. We'll see that it is common because one of the causative agents is a very, 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 very common drug. Okay? For the pancreas, endocrine tumors do occur, but the main one we fear, and then like the fourth leading cause of cancer death is the exocrine carcinoma. Diabetes mellitus, not really. In histopathology, we don't deal with diabetes mellitus. We'll mention the etiopathogenesis and what you see in the pancreas in a patient with diabetic mellitus. But the diabetic mellitus is more of a chemistry than a histopathology disease. Congenital lesions, we're only going to mention one. Okay, so the gallbladder, congenital inflammation, tumors, and the stones. And here I've said mainly stones and the inflammation. This is the gallbladder that I showed at the beginning. This is how the gallbladder normally supposed to look like. You can see it's a bit greenish. It's full of bile. This is the pancreas. This is how a normal pancreas looks like. It looks yellowish, a bit irregular, and this is the part that's attached to the duodenum. So gallbladder can be absent or can exist in unusual location. You can have a variant with a folded, what we call a folded fundus here, such that the fundus has come in. It's a folded fundus, normally what you call a Phrygian cup. It might be duplicated, it might be bilobed. Okay? And when you come to the bile ducts, sometimes they may not have been formed, or there's hypoplastic narrowing on the biliary channels, what you call biliary atresia. But this one we'll see mainly with a more of a liver pathology, because the bile ducts can either be inside the liver, near the liver, or outside the liver. And any of these can have a genesis, or hypoplastic narrowing, or atresia. Okay. By lobed here, you're seeing a gallbladder that has two lobes. You can see this one is different from that. These are rare. These are just by the way. Okay. Now, our main discussion will be on gallbladder, and this is the stones. These are common. These stones, or we call them cholelithiasis, these ones are common. Okay. So there are two types of stones. There are what we call cholesterol stones. Then there are those we call pigment stones, pigment or bilirubinate stones. The cholesterol stones, these are formed from cholesterol. Okay. So any condition that's going to increase hepatic cholesterol uptake or synthesis, or increase biliary cholesterol secretion, is going to give you cholelithiasis of the cholesterol type. Okay, then the pigment ones, these are formed from bilirubin. You can see the difference. This is bilirubin, this is from cholesterol. And you see even their morphology and the morphology of how they present, and then the risk factors will be different. Here, anything that's going to increase cholesterol will give you cholesterol stone. Here is mainly conditions that are going to increase unconjugated bilirubin, or is going to cause precipitation of bilirubin salts. And this one have a lot of calcium, so they tend to be radiopaque. You can see them on X-rays. This one, unless they acquire sufficient calcium, they tend to be what we call radiolucent. You don't see them on X-rays. But nowadays we don't use X-rays, we use ultrasound, and ultrasound normally is very sensitive to detect gallstones or cholelithiasis. Okay. Now, what are the risk factors for the cholesterol stones? We see them mainly in the Northern Europeans. This is American data. I'll tell you the current data here. North and South Americans, the Native Americans have increased risk. Yes. Mexican Americans, you can see from the Americans, the Black Americans seems to be less. But that's not true for us. I'll show you what we have. Advancing age, normally age more than 40. Okay, cholesterol stones are very, very common in the female gender, patient on oral contraceptives, patient with pregnancy, especially multiple pregnancy. It's also very common in obesity and in metabolic syndrome. Basically, this is from abnormal cholesterol metabolism. In rapid weight reduction, we have seen this. Again, abnormal excessive cholesterol breakdown. Gallbladder stasis, these ones, you have decreased secretion or decreased secretion of the cholesterol from the gallbladder, so that you have supersaturation of bile with the cholesterol. You can have inborn errors of bile acid metabolism, okay, or you could have hyperlipidemia syndrome, again related to cholesterol. And the simplest way of remembering this is normally what we call the classic 5Fs. We see this in patients who are fat, so there's obesity and the hyperlipidemia syndrome. We see them a lot in the female sex hormone, female gender, oral contraceptive, pregnancy. fair, this is somebody who is not dark skinned, light skinned. Yes. Let's say yellow, yellow. Yes. So fair here, and this is why you are seeing this in the Northern Europeans, you're seeing in the Native Americans. You see them in patients who are above 40, typically above 40, and again, patients who are fertile. Again, the issue of pregnancy, the issue of oral contraceptives. But we also see a lot of flatulence, it is gas, if you have a gallbladder stones, and also there could be a risk of family association. But if you remember the classic 5Fs, you'll be able to memorize or remember the whole risk factors. Typically, even in our setting, female, more than 40 years, multiparous, or on oral contraceptive, and who are obese. Okay, so fat, female, fair, 40, and fertile. This is for cholesterol stones. Please don't confuse this with pigment stones. Okay. Now, for pigment stones, we see them mainly in Asians more than Westerners, rural more than infections. Okay. But we see them again in a patient with chronic hemolytic anemia. So you can add the thalassemias, you can add the sickle cell anemias here. Okay. We see them in patients with biliary infections, so the E. coli, Ascaris lumbricoides, and the Opisthochis sinensis. This is a liver fluke. Also, patients who have had gastrointestinal disorders like ileal disease, ileal resection or bypass, patients uh, uh, with pancreatic insufficiency, like cystic fibrosis. Again, this can lead to bilirubin, yes, and this can predispose to uh, pigment or bilirubin stone formation. So these are the risk factors for pigment stones. Okay, nothing about the female, nothing about the weight, yes, and nothing about being a bit fair. You're just having a condition where you have an increased bilirubin, or you have an infection causing removal of the glucuronide from the bilirubin. Okay. Now, what's the pathogenesis for the cholesterol stones? Basically, when you have a cholesterol concentration exceeding the solubilizing capacity of the bile salts, so you have what we call supersaturation. Then the cholesterol nucleates into solid cholesterol monohydrate crystals, and then these cholesterol crystals they crystallize together to give you a stone. So the conditions that must be there for a cholesterol stone to be formed, there must be bile that is supersaturated with cholesterol. You have a gallbladder that is hypomotile, meaning that very little bile is being secreted out. So most of it is staying in the gallbladder. Okay. Then the cholesterol nucleation in bile normally now accelerated once you have that supersaturation. And then you have excess mucus secretion that traps the crystals so that these crystals that are formed, the small crystals that are formed, are trapped in the mucus and they're also not allowed to leave the gallbladder. So this process continues on and on and on until you have a visible, very many large stones. Okay. Let me show you this one first. So you have a biliary lipid here. You have mixed cells with bile salts, you have lecithin, you have cholesterol, And then you have a supersaturation. Supersaturation. Once you have a supersaturation, you have multilamellar vesicles, small vesicle of cholesterol now form. Okay? And combined with gallbladder hypermotility and cholesterol nucleation, you start getting filaments and crystals of cholesterol forming. And once they form, they conjoin, they form, they join together to form plates, okay, which accrete together, okay, mixed together due to the mucus hypersecretion, gallbladder hypermotility, and also the increased calcium salt. And then eventually now you have a cholesterol strain forming. Basically, it starts from you have an excess of cholesterol in the body. And then you have a nucleation with formation of a cholesterol monohydrate crystal. These crystals join together and then combine with the mucus hypersecretion, the gallbladder, see how they look like. For the pigment stones a bit different. Anytime you have unconjugated bilirubin, so most commonly due to chronic anemias or chronic multi conditions, and then a condition that can precipitate bilirubin salts. So we see this mainly in biliary infections. We've talked about E. coli, Ascaris lumbricoides, and also Opisthochus sinensis. These promote bilirubin glucuronide deconjugation. Basically, it means that bilirubin, when it's conjugated, it's normally water soluble. Okay, if you deconjugate it and you remove the glucuronide, it becomes water insoluble and it can precipitate out. And when it precipitates out, it basically now forms crystals. And then again, these crystals can accrete together and give you a larger stone. This is pigment stone. Okay? Now, how do they normally look like? What's the morphology? Gallbladder stones are normally only found in the gallbladder. Cholesterol stones, are normally only in the gallbladder. You can have stones in other parts of the body. You can have stones in the urinary tract, in the urinary bladder, you can have in the kidney, you can have in the ureters, you can have stones even in the salivary gland. But cholesterol stones are unique only to the gallbladder. And classically, they are hard, and they are pale, and they are yellow. Usually don't see them black unless they have some bilirubin salt, because you still have bilirubin even in that bile. Okay? And when they are predominantly composed of cholesterol, they are radiolucent, meaning they don't have enough calcium to be radiopaque. When you're talking about radiolucent here, we are referring to X-rays. Okay? Without calcium, something cannot be picked up with an X-ray. Okay? When they get significant calcium deposition, they can be radiopaque. Radiopaque meaning you can now see them with the X-rays. They can be single stones, okay? They can be multiple stones. Typically tends to be multiple, well-faceted, more hard, and more slightly better formed than what you're going to see with the pigment stone. Now, for pigment stone, they can be black when you don't have an infection, or they can be brown when there's a concurrent infection. And they're actually very soft. They're not as hard as the uh, cholesterol stones, and most of them are radiopaque because they have calcium. So if you're doing an X-ray and you find a gallbladder stone that is radiopaque that you can see, you're most likely dealing with the bilirubinate stones. Okay. How do they normally present? Most of the time they are asymptomatic. 70 to 80% are asymptomatic. but they can also present with biliary colic. They can present with biliary colic, like right upper quadrant pain, when you have an impacted stone. And the best form of diagnosing this normally through ultrasound. They have a lot of complications. They can progress to inflammation of the gallbladder. They can block the biliary tract. This is cholelithiasis, is stones in the biliary tract. They can give you pancreatitis. We are going to see that. They can give you inflammation of the biliary duct. This is cholangitis. They can block the biliary tract, giving an obstructive jaundice. They can give you pus in the gallbladder, that is empyema. They can cause perforation. They can cause fistulas. Yes, they can cause ileus. Ileus is when a stone passes through the biliary tract and blocks the intestine. We normally call it biliary ileus or gallstone ileus. It can give you excessive mucus production, filling the gallbladder, giving something called a mucocele, and they also been associated with that as a risk factor for carcinoma, as we shall see. Okay. So this is a cholesterol stone. You see yellowish, some slightly sometimes to get them being black, but they tend to be typically yellowish, like the cholesterol is. This is pigment stone, and they're typically very black with a very rough surface. Typical of a pigment stone, but you can see this is a markedly thickened wall. So this patient also most likely has cholecystitis. Okay. This is cholecystosis. This is cholecystosis. Basically, when the gallbladder full of cholesterol stones, then we are saying that's what we mean by multifaceted. Usually, when there are many. Okay, this is a lot of gallstones, and when you're doing an X-ray, sorry, this is not an X-ray. This is a ultrasound. You can see the gallbladder here. Then you can see the stones there inside. Okay. This is the gallbladder here. It's a bit distended, but these are stones in the biliary tract. So this will be choledocholithiasis, and this can cause obstruction of the biliary tract. Those are stones. We said stones are common. If there's one lesion you need to remember in the gallbladder are stones, gallstones. Those ones are common. The next lesion you need to remember in the gallbladder are the inflammatory lesions, and they are normally mainly just two: acute cholecystitis and chronic cholecystitis. Acute cholecystitis is acute inflammation of the gallbladder, and usually from cystic duct obstruction by gallstones. So the patient presents with acute biliary colic, right upper quadrant tenderness. They can have nausea, they can have vomiting, they can have fever, they can have leukocytosis, basically features of acute inflammation. Acute cholecystitis can complicate, can be gangrenous, can perforate, and then the perforates can give you peritonitis, can give you fistula formation when it now erodes into the intestine, and can also give you a gallstone ileus if it is coming from gallstones. Remember, acute cholecystitis can also arise from a background with no gallstones. So if it's arising from a background of gallstone, the term we normally use is acute calculus. Calculus. So if you see acute calculus cholecystitis, basically meaning it's coming from gallstones. But you can have acute cholecystitis that's not coming from gallstones, especially when you have a diminished cystic artery circulation. You have decreased blood flow to the gall. So that will be acute acalculous cholecystitis. This is associated with can be from surgery or a patient with trauma or a patient with sepsis. Okay? And this is not related to stones, artery circulation. Morphology, these normally are enlarged, it's tense, it's bright red, sometimes can be green black with fibrinous exudate. Basically, features of acute inflammation. And the luminal contents range from turbid to purulent. When it's purulent, means basically it has developed empyema. Empyema when you have accumulation of pus in a cavity. In severe cases, it could be gangrenous, okay, and it can even also perforate. In milder cases of acute cholecystitis, you just get wall edema, you get some hyperemia, can be very mild also. These are at the extremes of cholecystitis. So this is acute cholecystitis. You can have a cholangitis. Cholangitis now you have just bacterial inflammation of the bile ducts ascending up the liver. Okay, it could be from obstruction of bile flow, and also it could be from bile duct stones, like what we had shown you here. This one, bile duct stones. These are choledocholectasis. Of course, patients will have biliary colic, they'll have obstructive jaundice, they'll have high fever, they have chills. Again, features of acute inflammation. We see this one mainly with the gram-negative enteric bacteria, so the so-called so this is a inflammation of the bile ducts that's going up to the liver. The term we use is ascending cholangitis. Remember, there are other forms of cholangitis. We are not discussing them because those ones were discussed in your liver pathology, like primary sclerosing cholangitis and also primary biliary cirrhosis. Those are some forms of cholangitis. But the one we're talking about here is the acute one. Okay. Now, the chronic cholecystitis, it can be a consequence of repeated bouts of acute cholecystitis, but sometimes can develop without any antecedent attack. And most of the time, in chronic cholecystitis, is usually related to gallstones. But we think gallstone might not be the main reason. What could be the main reason that you get chronic cholecystitis with gallstones is the chronic bile supersaturation. Remember, we talked about bile supersaturation as a pathogenetic pathway. Saturation permits cholesterol to enter into the gallbladder wall, and that entry of cholesterol in the gallbladder wall creates inflammation and gallbladder. And this inflammation and gallbladder motility increases the risk of having stones. So sometimes it's not clear which one starts. But don't you know that patients with gallstones, repeatedly they'll end up with chronic cholecystitis. And even the patient population, the patient that researches tends to mirror those ones of acute cholecystitis, but in a more gradual onset. And it is the same patients that you're going to see with the with gallstones. Now, morphology, what do you normally see? The gallbladder can be fibrosed, can be smaller, can be normal size, or it could be enlarged and there's an obstruction. And the wall normally is thickened. The mucosa, all the time is preserved, the mucosa tends to be eroded in the acute phase. Mucosa sometimes can be atrophied. You can have cholesterolysis. Cholesterolysis is what we are showing you here. This one here. Cholesterolysis. Yes, it's like you have deposition of cholesterol on the wall. Cholesterolysis. And gallstones are normally frequent, so we see gallstones a lot in chronic cholecystitis. The inflammation is normally variable. You can have mucosal outpouchings. This mucosal outpouching is normally what we call Rokitansky-Ashoff sinuses. It's the same word. You can have a porcelain bladder. Porcelain bladder is a bladder that is calcified. The problem is the porcelain bladder is normally a risk factor for carcinoma. The gallbladder can be fibrosed, it can be nodular, it can have a foamy macrocytic infiltration, something we call xanthogranulomatous inflammation. You see, all this typically is features of morphological characteristics of chronic cholecystitis. You now don't see the acute inflammation. This is more of a chronic inflammation. Okay? And the clinical features, they tend to have recurrent attacks. They have recurrent attacks, yes, or colicky, epigastric, or right upper quadrant pain. They are more frequent now. I remember we said the initial phase of the gallstones, they tend to be asymptomatic, but they can now give you these recurrent attacks or mild colicky, epigastric pains that tends to be refractory. They are the same as for acute cholecystitis, so they can get bacterial spore infection. You can have a gallbladder perforation, abscess formation. You can have peritonitis, and you can even have biliary enteric fistulas being formed. And you also gallstones, and even these recurrent infections in the gallbladder can be a precursor, or it could be an increased risk factor for gallbladder carcinoma. Yes, these are stones. You see the stones there. This is a mucosa that is flattened. This is not how mucosa is supposed to look like. This is the wall is a bit thick, and you can even see the hyperemia and the vascular congestion. When you look under the microscope, there's a chronic inflammation here. This is the mucosa, but you're now seeing the mucosa inside the muscularis. This is the muscular wall. This is normally what you call the outpouching. This is the, if you're reading the books, what the books are calling Rokitansky-Ashoff sinuses are these ones. This outpouching that you see here. But the wall is thick, and the wall has features of chronic inflammation. That is a chronic cholecystitis. Very many, most likely related to gallstones. Now, gallbladder carcinomas again slightly more common in women because of the relationship to gallstones. Usually more common in women, usually after 70 years. I've seen them being much, much younger. I've seen this in a 32-year-old old. We just don't have the data. This they're related to gallstones, but most gallstones are asymptomatic. So when they are getting these gallstones at 40 years, the cancer will appear much later at around 70 years plus. Why some of these patients get cancer very early? It could be the issue of inherited changes in the DNA, yeah, like overexpression of what we call ABB2. This is the equivalent in our setting because we have a lot of cholesterol stones. We see them a lot. And we think this chronic gallbladder inflammation, the chronic cholecystitis, could be a critical risk factor for the carcinoma. Pigment stones doesn't tend to give you this problem. This problem we're seeing mainly with the cholesterol stones. So patients who are with the pigment stones then have most of this problem. But the causes of pigment stones, if you still remember the causes of pigment stones, remember the pigment stones. Yes, like the Opisthochis mensis. Yes, this is a parasite and it can predispose to gallbladder carcinoma and also biliary tract carcinoma. If you're being asked about a parasite that can cause carcinoma, remember Opisthochis sinensis, remember schistosoma hematobia. Yes. So most of this could be due to gallstone. You can have other mutations, but HER2 mutation is very common. Okay. And the gallbladder carcinoma, if you look at the morphology, they can be infiltrating tumors, meaning they infiltrate the wall because they fuse thickening. Yes, they can be exophytic, meaning they are protruding into the lumen in a cauliflower-like mass, and most of them are adenocarcinomas. They can be other types, but they can even have squamous, you can have adenosquamous, you can have carcinoid, you can have mesenchymal, but most of them are adenosquamous, either from the biliary type or the intestinal type. Okay. They can spread via the liver invasion, they can spread by the ducts, they can spread by the nodes in the peritoneum and the lung. Some of them you find that you see variable histology, either limited infiltrating the wall or presenting as an exophytic tumor. What do you feel about them is that they're normally asymptomatic until very late. They might present with some features of cholecystitis, so they're normally sometimes taken as cholecystitis. And these are diagnoses we make at histopathology. The physician might not even realize that their patient have carcinoma already. So you are getting a gallbladder that has been removed that, with the clinical diagnosis being given as a cholecystitis. Then now when you're trimming it and you're looking at it, under the microscope you find large areas of carcinoma. And by the time you're seeing that, basically means it's a late stage. A late stage. Yes. So you can have an enlarged palpable gallbladder, you can have obstructive symptoms like obstructive jaundice. And the X-ray might show a calcified or what we call a porcelain gallbladder. Okay. Prognosis normally is terrible, less than 12%, because most of the time they are discovered at an advanced stage. And also they are mistaken as innocuous Yes, you can see this one has stones, but there's a mass here. This is the normal gallbladder wall. There's a mass here. There's an exophytic tumor. This is tumor. This is the normal mass. This is normal gallbladder. It's an exophytic tumor. This one here is bile stained, but again, this is the gallbladder. You can see an exophytic tumor. But there, under the microscope, there are adenocarcinomas forming some glands. These are not well differentiated glands. No, so these are moderately differentiated glands. This one now you're seeing the mucosa here, and then you're seeing the glands now right inside the muscle, from well differentiated to poorly differentiated. And they are, but mostly they are adenocarcinomas. You can also have bile duct cancer. What we have discussed was gallbladder carcinoma. You can have a biliary duct cancer outside the liver. So in the inside the liver, we call them bile duct carcinoma or cholangiocarcinoma if they are intrahepatic. You can have carcinomas at the bifurcation of the right and left hepatic duct. Normally we call them Klatskin tumors. Then you can even have opisthocis sclerosing cholangitis. Prognosis tends to be terrible. Again, they're normally discovered when very late. Even their resection is not easy to resect. Okay? We are saying you can have a antihepatic cholangiocarcinoma, meaning it's inside the liver. Intrahepatic cholangiocarcinoma, or you can have a perihilar around the hilar. The Klatskin will be here when you have this bifurcation of right and left, right and left hepatic duct. So when you have a tumor here, it's normally what we call Klatskin tumors. Or you can have a perihilar cholangiocarcinoma, or you can have a distal cholangiocarcinoma, like in the common biliary tract. Resecting this one tends to be very difficult. You have a lot of vessels here. There tends to be most likely either they have formed multiple. You can see like this one is forming multiple foci of tumors. Resecting all this can be difficult, and sometimes you can have them along the tracts. They can be intrahepatic, it can be around the hilum, perihilum, or it can be in the distal. All these are still called bile duct carcinomas. You can have adenocarcinoma of the ampulla of Vater, that part of the duodenum where the pancreatic duct joins. And because it's the ampulla, it can have either duodenal. We have mentioned the name here because, again, they can also give you what we call this. If you see a patient with feature, still think of a pancreatic tumor or a ampulla of Vater tumor. They have a terrible biliary tract, the same that we see with the gallbladder. Not very good kind of prognosis. So that was the biliary tract. Yes. This is the duodenum. Okay. And there is a tumor here coming from outside, going like this. So the tumor is around this is the ampulla of Vater. So there's a tumor here. There's a tumor around there, ampulla of Vater. I'll show you the ampulla of Vater better when we reach to the pancreas. So that was the gallbladder. We said mainly inflammation, cholecystitis, acute and chronic, gallbladder carcinoma, and the main pathology here being stones. Now, for the pancreas, again, we are mainly going to deal with pancreatitis, and then the tumors, and for the tumors, malignant tumor. The rest, and by the way, diabetes mellitus, we said, biochemical, dysfunction that should be covered as an endocrine disorder and not as a pancreatic lesion per se. Yes, so here again, you say this is the pancreas. This is how normally a well-looking normal pancreas is supposed to be. And then you have in histology, you see the acinar, and then you see the islets. So these are the acinar cells that produce the exocrine. These are the ones that produce the trypsins and the pancreatic lipases and the pancreatic amylases. And these are the ones that now produce the hormones, glucagon, VIP, gastrin, and the insulin. So these are the islets. So normal pancreas, the exocrine, the makes enzyme for digestion. So the diseases that we see in the exocrine pancreas is pancreatitis, cystic fibrosis, and even tumors. The endocrine pancreas makes insulin, glucagon, and secreting the tumors. I mean the hormone. Okay. Congenital normal the pancreas, you can have pancreatic agenesis. Pancreatic agenesis is incompatible with life. You need a lot of pancreatic enzymes for digestion. Pancreatic divisum, I'll show you what divisum is. It's a variant of pancreatic duct anatomy. Annular pancreas is when the pancreas circles the duodenum and presents as an obstruction, or you can have an ectopic pancreatic tissue. So there's one a pancreatic tissue resulting duodenum appearing in the jejunum. Ectopic pancreatic tissue, or what we call pancreatic heterotopia. And they can also be they can have hemorrhage, they can become inflamed, they can also produce the endocrine tumor, especially like this one. We are trying to show you this is the small intestine. The mesothelium has a tumor here. And then under the histology, you see tissue that looks like pancreas. It's basically pancreas. So this is a pancreatic heterotopia. This is ectopic pancreatic tissue in the small intestine. Now, the pancreas normally develops from from one's ventral lunge, and then you have a dorsal lunge, and then they rotate. So during that rotation, you can have the pancreas remaining. This is the annular pancreas. Annular pancreas. Now, for the pancreatic divisum basically is that the dorsal is the one that's supposed to support. This is what's supposed to combine with the common bile duct to ampulla. But sometimes that does not occur. This is the normal development. You have the common the main pancreatic duct, and ending up with the major papillae into the ampulla of Vater. Then you have a small minor papillae here. So some of it from the dorsal goes into the minor papillae. So the normal situation is that you have a common bile duct, the main pancreatic duct, opening into the major papillae, and which is going to open into the ampulla of Vater. In the pancreatic divescum, on the pancreatic divescum, what happens that the common bile duct does not match with the major duct, the main duct. It actually merges with the minor duct or the ventral duct. And this minor duct is the one that's going to open into the ampulla of Vater. So the largest portion of the pancreas is left to use the minor papillary. And we shall see why this can be a problem. The main result is that you'll end up with a lot of pancreatic secretions not reaching the duodenum. You can get acute pancreatitis. We'll see how that occurs. You can see like this one here that the dorsal pancreas is opening into the minor. Yes, and the ventral pancreas is the one now going into the major. So the biggest chunk, the biggest portion of the pancreas is not being drained sufficiently. And you can see this pancreas is also here. It is circling. It is circling the duodenum, and that will be the pancreatic or the annular pancreas. I have another one here. Yes. So the bile duct comes, meets the major duct, and opens into the major papilla in the papilla of Vater, or the ampulla of Vater. Now, in the divescum, the major duct is left to fend for itself and use only the minor sphincter. So the common bile duct meets the minor duct. And this minor duct, as you can see, is only serving a small portion of it. Is left to use the minor sphincter. So it is not being well served. That is the pancreas divescum. This is the most common anomaly that we see in the pancreas. Now, okay, the pancreas protects itself. It produces a lot of digestive enzymes. Digestive enzymes that are strongly protein. Why is it that they normally don't digest the pancreas? It happens that most of these pancreatic enzymes are normally produced as proenzymes or zymogens, and then they are packaged within secretory granules. And then the zymogens only become functional when they are cleaved by trypsin. And this trypsin is not activated until the precursor is also produced as a trypsinogen and encounters the enzymes in the duodenum, the enterokinases. So that this activation of the small bowel. Then the arsenal duct process also be activated in the pancreas, because if you activate in the pancreas, it is going to activate the proenzymes into digestive enzymes, so that intrahepatic trypsin activation is limited by serine protease inhibitors. The best one normally was called serine protease inhibitor, casal type 1 or SPINK1. And this limits intrahepatic trypsin activation. When there's low calcium also ensures that trypsin cleaves and inactivates itself. That in an area where there's low calcium, there is a activation of trypsin to inactivate itself. So these are the mechanisms that these four mechanisms are what enables the pancreas to defend itself or to protect itself from its own arsenal. And this arsenal here is the digestive enzymes digesting itself or exploding prematurely. You see, like you're making bombs, but you make sure that these bombs don't explode prematurely or these bombs don't are not used to attack your own country. So you put in a protective mechanism. That these bombs should only explode once they are outside the country. So these proteases or the pancreatic proteases are only activated in the duodenum. So when you have a miscalculation or you don't, these protective mechanisms are not put in place, then that's the time now you'll have conditions like acute pancreatitis. Okay? Now, acute pancreatitis basically results when these mechanisms fail or they are made to fail by some risk factors. And that leads to reversible destruction of the pancreas. Reversible means it is not too much. Yes, if it's just part of the pancreas, it can be reversed. And the mechanism here normally is inappropriate release and activation of the pancreatic enzymes, which digest parenchyma and then elicit inflammation. Inflammation can start from bacterial infection. Inflammation can also start when you have a necrotic tissue or necrotic debris. And the key event here we think is a activation of trypsinogen. If trypsinogen is inadvertently activated, it's going to activate the elastases. It's going to activate the proenzymes that are in the pancreas. And the elastases will digest blood vessels, causing structural damage. And this is where the hemorrhage will come in. The phospholipases that will be activated by the trypsin will lead to adipose tissue injury, will lead to fat necrosis. And the trypsins will activate kallikrein, triggering coagulation, triggering complement pathways. And the moment complement pathways and coagulation are triggered, you have the disseminated intravascular coagulation. You also have persistent activation of the inflammatory pathways. So acute pancreatitis will most likely be from failure of these uh, four mechanisms. And trypsin activation is the key event. Inadvertent trypsin activation. The main causes, if you're asked, alcoholism and gallstones, 80%. And you can see these are common. Yeah. Remember when I told you a very common drug? Alcoholism, this is a very common drug. Gallstone, we said common. That will actually tell you that pancreatitis can also be common. Other causes could be hypercalcemia, you can have drugs, can have shock, can have infections, can have trauma, and diminution and even lead to acute pancreatitis. How it does that, we are going to discuss as we go along. Growth, you get hemorrhage because of digestion of the blood vessels by the elastases. You get liquefactive necrosis. You get fat necrosis. And then when this fat is necrosed, you form a complex fat. When you deposit calcium in complex fat, you end up with a chalky substance, chalky soapy substance. Okay, closely that's how it looks like. Microscopy, you have liquefactory necrosis of the pancreatic parenchyma, you have acute inflammation, you have enzymatic fat necrosis, and you have blood vessel necrosis. This is normally coming from the prematurely activated or wrongly activated pancreatic enzymes. Complications of acute pancreatitis, acute respiratory distress syndrome. Yes, this is when now the lungs fail. Lungs can fail as part of what we call systemic inflammatory response syndrome. You can have disseminated intravascular coagulation. Remember, we said this normally triggers the calculin, the trypsin triggers calculins, and calculins can trigger intravascular coagulation. Intravascular coagulation can also last from the vascular damage with the activation of the endothelium. Can have a pancreatic acidosis, I'm going to show you. Can have pancreatic calcifications. This is from the fat necrosis with calcium deposition. You can have hypocalcemia again because when you have necrotic fat is going to absorb calcium. So for calcium, remember, excess calcium, hypercalcemia will trigger acute pancreatitis. But acute pancreatitis can, because it's going to now use up the calcium that is there, it can present with hypocalcemia. And prognosis can be very severe. In severe cases, 30% will die. So it's a very severe, and typically the presentation that you're going to see is these guys went out and then they went drinking. Then the following 2 days, this guy is very sick, this guy is worsening. By day 3, this guy is dead. Okay? That is when you have a extensive and necrotic acute pancreatitis. And they are dying because of some of these complications. Okay? For guys who normally want to use pneumonia, idiopathic, gallstones, very common, ethanol, most common cause, can have trauma, can have steroids, can have mumps and even malignancy, can have autoimmune disease, scorpion sting, hypertriglyceridemia, and even hypercalcemia. When this patient is done ERCP is it's a procedure. We call it endoscopic retrograde cholangiopancreatography. When you want to look at the biliary tract, we put endoscopy and then we put another tract to go through here. Yeah. This is another tract, put a smaller tract to pass here, go all the way into the pancreatic duct. You can even do it. So it's coming, you're putting the tract from here and then it's coming here. It comes, and then you put it there, it goes out, or it goes back into the biliary tract. This is ERCP. Because sometimes you can inflame the acinar cells, and that inflammation of the acinar cells can predispose to inflammation. Drugs, hydrochlorothiazine, adenosine, pentamidine, a lot of drugs. The viruses, the best example here being mumps, the Coxsackie, hepatitis B, cytomegalovirus, varicella zoster, herpes simplex, and HIV. Bacteria, mycoplasma, legionella, leptospira, salmonella, even fungus, aspergillus, and even parasites Toxoplasma, Cryptosporidium, and Ascaris. This can cause uh, pancreatitis. I get smashed. Okay. So we are saying that you can have cell injury, like from alcohol, or you can have pancreatic duct obstruction, like in a gallstone. And what ends up is your enzyme leakage. And then enzyme leakage, part of these enzymes can destroy the blood. Part of them will leak into the bloodstream. Then you can test. So normally for biochemistry, we test for amylase, we test for lipase. If this is increased, we know this patient could be having acute pancreatitis. Lipases normally digest fat, you end up with fat necrosis. Proteases normally digest blood vessels, you end up with blood vessel destruction and hemorrhage, you end up with acute pancreatitis. In short, what this was saying, there are three mechanisms. Three. You can have a duct obstruction, you can have acilar cell injury, the enzymes or the proenzymes. Obstruction can be caused by cholelithiasis, giving you a pillar obstruction. You can have chronic alcoholism. You can have ductal concretion. When you have an obstruction, you have interstitial edema, you have impaired blood flow, you end up with ischemia. And this ischemia will give you acinar cell injury. Then once you have acinar cell injury, you have activated enzymes being released. And these activated enzymes digest the interstitium, attract inflammation, give interstitial inflammation edema. They can give you proteolysis, they damage the proteins around there. They can, or you can have ab initio acinar cell injury, like drugs, alcohol, trauma, ischemia, viruses, hypercalcemia. You have release of intracellular proenzymes and lysosomal hydrolysis. You have enzyme intra-activation, both intra and extracellular, but still within the pancreas. This will give you again increased acinar cell injury, then you activate the enzymes. Or sometimes you have defective intercellular transport, like metabolic injury, like alcohol, again from duct obstruction. So you have the poor delivery of the proenzymes, and when you have poor delivery of the proenzymes, you end up with the intercellular enzyme activation. And these enzymes are not supposed to be activated intercellular, they'll damage the acinar cell. And you'll have again the other downstream effect. So three mechanisms. And in fact, most of the risk factors will fall into this, either duct obstruction, acinar cell injury, or defective intercellular transport. This is the duodenum, and you can see a very hemorrhagic, very hemorrhagic pancreas, and you can see this hemorrhage and necrosis is extending into the fat. This is a severe hemorrhagic pancreatitis. This is mild hemorrhage with necrosis. This is a severe hemorrhage with necrosis. Yes. Under the microscope, you're just seeing hemorrhage with the inflammatory cells. The acinar cells are now, this is acute inflammation. So what you're having here is acute hemorrhagic pancreatitis. Here what we are having here are fat cells, but they are necrosed. And this bluish material you're seeing here is fat. So it's calcium. So we normally have, it looks like chalk. So what you have, call them fat necrosis with saponification. Saponification. Yes, this is acute pancreatitis at its worst. Now the chronic pancreatitis is a bit different. again, but you can see again the cause is still alcohol. But what you see here is not the acute inflammation. Now here you see mainly the chronic inflammation. And the chronic, you think this is now here you don't see the necrosis. You see a pancreas that is firm, that is white, and that's fibrotic. And the microscopy, you see extensive fibrosis, you see atrophy of the acini, you have chronic inflammation. And your patients normally have the endocrine and the exocrine. They'll have calcification because again, there's an ongoing chronic inflammation. Sometimes they can develop what's called acidosis, and of course diabetes because they normally have a poor prognosis. But you can see the guys who are affected, mainly alcoholics. This is almost synonymous with alcohol. Poor prognosis, 50% mortality over 20 years. Because most of the time they are not going to stop drinking. So in acute pancreatitis, you get more of acute inflammation. Yes, the activation of digestive enzymes, you have acid injury, you have vascular injury, you have acute inflammation. If you stop the drinking or stop the injury, you can have some resolution. But for the chronic pancreatitis, cytokines like transforming growth factor beta and platelet-derived growth factor. You have laying down proliferation of stellate cells. You have fibroblast laying down collagen. So you have what we call extracellular matrix fibrosis is going to cause acinar cell loss. So you can just say this is more of acute inflammation. This is yes. This is again the small bluish dots you are seeing. Those are lymphocytes. The acina is not there anymore. Allow me to show you the normal first, that you see the difference. Yes, this is how a normal pancreas is supposed to look like, even the growth. You can see these are the acina and these are the islets. So here now you are just seeing chronic inflammation. You are seeing chronic inflammation. The acinas are very few now. This is fibrosis. Fibrosis. Again, this is fibrosis. These are the remaining acina. This again is intense in chronic inflammation. These are the ducts. Again, fibrosis. So it's like the ducts are being damaged. Just chronic inflammation. Okay. Acidosis is when something forms like a cyst without a lining. This is the liver. No, that's not the liver. That is the spleen. This is the pancreas. This is the pancreatic wall. You can see it's markedly enlarged. But what you can see is a cyst. This is a cyst that is very hemorrhagic inside here. That's what you're seeing. This is the pancreas, and what you see is the cyst. Normally what you call a acidocyst. And normally it's acidocyst because it has no lining, but what you see down here is a chronic inflammation. Acidocyst as a complication of acute pancreatitis or chronic pancreatitis. Diabetic mellitus, we said we're just going to mention in passing. Chronic systemic disease characterized by insulin deficiency or insulin resistance, resulting in hypoglycemia and non-enzymatic glycolysis. Acute complications will be either from resulting in hyperglycemia, not hypo, hyperglycemia. The acute complications we are going to see is due to hyperglycemia. The chronic complications you are getting, there are two types, and now there are too many types. There's the insulin-dependent percent of the diabetes mellitus, they turn from autoimmune destruction of the beta cells. And they normally have complete lack of insulin. The etiology is most likely autoimmune type 4 hypersensitivity reaction. Yes, type 4 cells attacking the islet. You see insulitis. Insulitis when you have inflammation of the islet cells, you have a beta cell loss, and you have fibrosis of the islets. And this patient will have a 3P. And sometimes they develop. Yes, this is the athena. Now the athena looks okay now, but the islet cells have a lymphocytes. They're being attacked by lymphocytes. In this case, again, you can see these are the athena cells. This is the exocrine, but these are the islet cells. And this islet deposition of either collagen, fibrosis, or sometimes can be a protein called amyloid. But in the results that the islet cells are this loss of islet cells. Okay. The type 2 diabetes, usually from adults, because of the age, this is more of reduced insulin secretion and also peripheral insulin resistance. And here in the microscopy now, we don't see those typical changes like in the type 1. Yes, they are frequently asymptomatic. They can have 3Ps, but here they don't get DKA because they don't have absolute lack of insulin. They get what is called hyposmolar non-ketotic coma or hyposmolar hyperglycemia. I said at the beginning that this lecture is from systemic pathology, so it would be unfair if I drag you into the biochemical characteristics of diabetic mellitus. You can have pancreatic tumors in the endocrine section, so like islet cell tumors. You can have insulinoma. Insulinoma is going to produce excess excess insulin. If you have excess insulin, you end up with hypoglycemia. So you have features of hypoglycemia. Like the hypoglycemia, you have the sweating, you have the hunger, confusion, and sometimes you end up with insulin coma, insulinoma, or a beta cell tumor. Surgical excision tends to be more curative. A gluconoma produces excess glucagon. If you have excess glucagon, you end up with a hyperglycemia. So you end up with diabetes, you end up with anemia. Sometimes they also get a skin rash. Glucagonoma. Gastrinoma, remember we have talked about gastrinoma when you're talking about multiple refractory due to excess gastrin production. Excess gastrin production manifests as Solling-Gilson syndrome, thick gastric falls, table peptic ulcers. But remember that gastrinomas may also arise outside the pancreas, and they're normally associated with what's called multiple endocrine neoplasia. Again, you taught this very well when you read endocrine pathology. Excess gastrin. Sometimes you can get excess somatostatin, so that will be somatosenoma or a B-cell tumor, produces somatostatin. So somatostatin normally inhibits insulin secretion, so they lead to diabetes. It can also inhibit gastrin secretion, leading to hypochlorhydria. It's low acid level. It can also leading to gallstone. When you have cholecystokinine, decreased cholecystokinine secretion basically means that bile secretion is reduced. When bile secretion is reduced, you end up with the gallstone, you end up with the steatorrhea because you need bile acid to absorb lipids. This one normally has a poor prognosis. Okay, if you remember, who remember Steve Jobs? Again, for medical information, we only give you things that are in the public domain. Who remember Steve Jobs? Anybody who knows Steve Jobs? It seems the young generation are just using AI without knowing who started the AI. Okay, I'll leave you to go search on Steve Jobs and the relations to pancreatic tumors. The bad thing with them, these pancreatic, some of them can be mild, some of them again gives you non-specific symptoms, meaning they're discovered extremely late. I'll go to the main tumor of the pancreas. You can have a vipoma. A vipoma produces a vasoactive intestinal peptide, and vipoma causes a disease which produces watery diarrhea. Because you're having watery diarrhea, you also lose potassium-rich intestinal fluid, and on top of that, they end up with a low these are neuroendocrine tumors or pancreatic tumors of the endocrine side. They're not common. The main one that we should know is this. When we're talking about the pancreatic carcinoma, now we are referring to the exocrine, either the duct or the acina. And this is just a snapshot of the pancreatic carcinoma. It's the fourth leading cause of cancer. This is USA with their good but highly disintegrated excellently funded, excellently resourced healthcare system that has a lot of discrimination and is expensive, but they're still dying from pancreatic carcinoma. The biggest risk factor for pancreatic carcinoma is smoking. Sometimes I still wonder how smoking is legal. I think smoking is legal if I produce in some politics is because we think the guys who make the cigarettes are white men. I have a feeling if it's only black people making cigarettes, they'd have shut it down long time ago. Yes, the biggest risk factor is smoking. And you can see that smoking also causes the number one leading cause of cancer death, which is the leading leading cause of cancer death in both women and men is which cancer? Bruce Nderu, which cancer?
Uh, Small cell carcinoma of the lung.
Bruce, you're muted. Unmute yourself.
thinking small cell carcinoma
Yes,
of the
which
lung.
cancer? The number one leading cause of cancer deaths worldwide. You can type if your audio is not good. Bruce, you're almost there. Basically, it's lung cancer. Because you see, a small cell carcinoma of the lung, the most aggressive, terrible disease, but even squamous cell carcinoma of the lung is still related to smoking. But the number one cancer death in both men and women is lung cancer related to smoking. The fourth one is still related to smoking. Now, age around 60 to 80 years. Here you see them much earlier. Don't know why. See them at 50s. The location matters because if this location is located in the head, it will present early. Because if it is in the head of pancreas is here. This is the head of pancreas. So if this tumor is here, down somewhere there, it's going to block the bile duct. And when you block the bile duct, you'll get obstructive jaundice. So it will appear earlier. If it is here, nothing will appear. If it's there, nothing much. It's because they are nothing much. We are saying that these ones appear early, so there's something you can do about it. We live in know that there's something there. These ones will appear very late when there's basically nothing you can do about it. That's the only issue there, location. Yes, the gallbladder, the head, they appear much faster. Head, you can find in the body, you can find them in the tail. They're normally silent until late, and that's their killer feature that you rarely get symptoms. And by the time the symptoms are there, there's nothing much can be done. They can present with obstructive jaundice, they can present with thrombophlebitis because they normally produce a thromboplastin-like material that can cause a disseminated form of coagulation. Microscopy, they tend to be adenocarcinoma. They are arising mainly from the duct epithelium. Sometimes they arise from the epithelium. They have desmoplasia. I'll show you what desmoplasia is. They normally also have perineural innervation. They have a very high mortality rate, a 5-year survival rate of less than 5%. We are saying is that if you have 100 patients, only 5 will be alive, rate of 10%. It is again the same thing that 1 out of 10, only 1 will be alive in 1 year. And these are the kind of cancer where people are given months. They've been given 6 months. It tends to be typically this. And the other one in the brain called glioblastoma multiforme, and also in acute myeloid leukemias. Okay. Pancreatic carcinomas, because it's happening in the USA, they have studied it extensively, and they found that there are a lot of oncogene, there are a lot of cancer gene mutations. Both the oncogenes, I'll give you this to read, the KRAS, the MYC, the BRAF, and then you also have the tumor suppressor genes, the cyclin-dependent kinase inhibitors, P53, SMAD4, BRCA, and even what we call epigenetic mutations. Okay? And some of them can be inherited with other disorders, like the Peutz-Jeghers syndrome, like the Li-Fraumeni syndrome, like the BRCA1 syndrome, and even the microsatellite instability syndromes like hereditary non-polyposis colorectal cancers. So you might have this also occurring. So you might have colorectal cancer. The biggest risk factor we've talked about is smoking. And how this families of pancreatic carcinoma, especially BRCA2, yes, germline mutations in the CDKN2, this is cyclin-dependent kinases. And also, diabetes mellitus normally impose a moderate risk for pancreatic carcinoma, but biggest risk, smoking. Metastases are normally very common, and 80% of the pancreatic carcinoma are unresectable at presentation. Most of them have massive liver metastases. We normally don't resect tumors that have metastasized. They're very few. Metastasis normally is a contraindication for doing surgery. The outlook we have said is normally dismal. 5-year mortality rate exceeds 85%. 5-year survival rate is less than 5%. Sometimes they can get complicated with the migratory thrombophlebitis. This is basically inflammation of the vessels, basically the veins, with a superimposed thrombus formation. Pictures. This is the spleen. This is the liver. And in between, you cannot even tell where the tumor is starting and the tumor is ending. That's why we are talking about the unresectable. You can call this normal pancreas, but here you are not sure. You're not sure where is where. So this one you cannot do surgery on. And most likely this is a postmortem specimen. And we have said most of them, yes, they are adenocarcinomas. You can see the acina cells here, there. Very fibrous, poorly demarcated tumor. This is another gland, but it's not a very well gland. And then you see fibrosis, a lot of fibrosis are there. This is normally what we call desmoplasia. Desmoplasia is a fibrotic reaction to malignant tumor. You can have others, but the main one here is just the pancreatic adenocarcinoma. You can have other benign ones like cystic neoplasms, serous neoplasm, like what we are going to see in ovarian tumors. You can have a mucinous neoplasm, what you're also going to see in ovarian tumors. But the main one I'm interested in is the pancreatic adenocarcinoma. I'm glossing over this because these are not common things. And I'm glossing over this because the only one I want you to remember mainly is the pancreatic carcinoma. In the gallbladder, think inflammation, think tumor, think stones. In the pancreas, think acute and chronic inflammation, think exocrine, pancreatic carcinoma. Any question?
Yes, Doc.
Peter, you're saying something?
Yes, I read a story about the Steve Jobs, and
Yes.
Steve Joe, I think what he was saying that he spent most of his money, most of his time looking for money than maybe building relations, and yet money could not save his life. And
Yes,
he was diagnosed with pancreatic neuroendocrine cancer that they said it was
yes,
different from pancreatic adenocarcinoma. And
yes.
they say that that was a slow growing cancer that
Mm-hmm.
was actually treatable or more
Mm-hmm.
manageable as compared to pancreatic adenocarcinoma. But after a while, the condition reoccurred, and
Yes.
between the pancreatic neuroendocrine carcinoma as compared to the pancreatic adenocarcinoma.
Oh, now remember at the beginning we said pancreas has two portions, both anatomically and also physiologically, the endocrine and the exocrine.
Exocrine.
So
Yes.
carcinoma, we are referring to the exocrine, but carcinoma comes from in short, carcinomas will arise from the acina here. Yes. The neuroendocrine tumors will come from the islet. They'll come from the islet. And the best term to use is neuroendocrine tumor. Avoid using the term neuroendocrine carcinoma because that definition you leave it to us. You can use both neuroendocrine tumor stroke carcinoma because those are two different things, slightly different. But for the question you have asked, when you're talking of a tumor arising from the acina and the ducts, the term is pancreatic adenocarcinoma or pancreatic carcinoma. When you're talking about tumors that are arising from the islet cells, the best term would be pancreatic neuroendocrine tumor. So the insulinoma, the choriogonoma, the lipoma, the gastrinomas, those are neuroendocrine tumors. And remember, I said the neuroendocrine tumors, their prognosis is unpredictable. And that's why for jobs they thought they could manage. I think they even did a liver transplant, but the tumor occurred. You cannot predict it very well. But for the carcinomas, we know it's just bad. Yes, guitar.
Yes, thank you. And then on the mumps virus, we know it affects the thyroid gland
Yes.
to cause pancreatitis.
Well, we remember we said there are three mechanisms. Look at this. Yeah. Acina cell injury. So the mumps now will infect the acina cells, viruses. And once you injure the acina cells, the uh, the control of that acina, and once you have that intracellular, this will worsen the acina injury. And now you have this downstream effect. We all say that these pancreatic enzymes are supposed only to be active. Is that okay,
Okay.
Gita? Okay.
Yes, that's okay. Thank you.
Okay. Any other question? If there's no other question, I think I'll stop there. I'll organize with the class rep. I share the notes. I think I'll add a few previous questions so that you know how you normally ask questions on this topic. This day.